because the lecture will be practically similar, very similar, because the results are only one which we have, of course. Lengthening of long bone by destructive osteotomy was here mentioned already by Professor Novikov. We in the past time used Elizarev or Poldy fixation, external fixator, and we make lengthening of several type of bone. We make 264 lengthening of long bone, mainly lengthening of tibia, but we make also 93 lengthening of femur. Complication which lead to our idea of lengthening overlocking nail are not so very rare. You can see that we divide our complication, we divide it into small complication and large complication. And if you can see that toilet pin infection brings to mean that we must make aggressive toilet, have practically all patients which are under lengthening with pin fixator. We have seen from this statistics that frequency of complication, large complication, depends on the length of lengthening, so that means the interval which we need. Frequency of small complication depends on the time of application. So to diminish it, it's better to reach better stabilization and removing external fixation as soon as possible. You can see some complication here. It is fixation on Wagner's apparatus for femur. Just runs very good with good production of the bone. When we remove it, it bends to this position due to mainly due to patient in cooperation. So we must make plate fixation with wave plate. So we look for a new method, and we have experiences with locking nail and experiences with lengthening. So we combine this method and make another method to bring improvement for our patient. We are not first. Boston and Larsen use intramedullary nail as we, but they don't lock the nail. In I think in Estonia, Igor Wasserstein used also lengthening on very strong key wire to diminish angular deformity, but then he replaced the bone, the interval of the bone, with solid graft. We published it firstly in Czech in 1994, and this method brings us the application of external fixation shortened on 1/3 of time and brings low complication rate and higher satisfaction of the patient. This is methods which avoid angular deformity, stabilized new form, so-called soft bone, and allows weight bearing as soon as possible. And the surgical technique is relatively simple. The first is application of the nail, then make osteotomy on the nail. Proximal locking of the nail is next step, and application of external fixation and start destruction. You can see that we start with femoral lengthening because it makes the bigger amount of complication. We find place for application of upper part of external fixator in trochanteric massif, and distally we find all-time place for minimally one screw, which can allow destruction, and when we have enough space we can add some screw more. So surgical technique was relatively clear. Destruction of osteotomy we make in daily sitting, for daily sitting 1 millimeter, so a quarter of millimeter every 6 hours. We try to make it a little bit quicker, and it doesn't seem that it makes any harming of the development of the bone, but the patient don't like it very much. We can, of course, make correction of the position of external fixation. That means that I think that we add new pin if it was necessary. When we finished with desired lengthening, we distally locked the nail. For this locking is ideal banded fixator Prospon of Czech production. They are here also, which allow to lock without removing of the external fixation, and then of course extraction the fixation when we lock the nail. Physical therapy is immediately, and extraction of the nail we allow minimally 1 year after. So advantage is safety for the patient, it brings quick therapy, quick physical therapy, and it brings low complication rate. Here you can see some patient which we make. This is application of the rod, external fixation, osteotomy is here, we can make destruction, and when we make desired destruction, in this cases it was 4.5 centimeters, we lock it distally and take fixator away. So the application of the fixator takes 45 days. That's enough for the patient, so it's quite good for them. In other cases with chondrodysplasia patient, there was lengthening of 8 centimeters. Here you can see one side is already lengthened, the second side start. The same procedure, application of the rod, external fixation and osteotomy, destruction, and when we have made destruction we lock it. You can see that the development still continue, and the patient after that is quite satisfied. We have made with this method 53 patients, 41 lengthening of femur, 12 tibia. Average length of lengthening was 6.8 centimeter. Average time of application of external fixator was 62 days, millimeter per day, and then take away the fixator. We have also some complication, but it was relatively rare complication. One was fracture on the nail, and one was bending of the nail, and the patient have a car accident. The lengthening was mainly 6 to 7 centimeter, but we have also lengthened one patient 13 centimeter. Average destruction was 6.4 centimeters, as I have mentioned already. Average age was 26 years. We lengthened older patient till 45 years. It was the oldest. And average destruction index was 9.1 days, so we reached 1 centimeter in 10 days. Here you can see that the destruction depends, of course, on the length of destruction, but the destruction index remain practically the same, or in longer destruction is a little bit depressed, little bit lower, because we allow to the patient when they feel good to make destruction quickly. Healing index, it's very hard to say because you have the rod, so we control quality of the bone on the X-ray. When we have two cortical bone, solid cortical bone, we suppose that it is healed. It was 28 days per 1 centimeter. We have complication, of course. Here you can see the bending of the rods, which we it was patient which go home from the hospital and have car accidents, go back, and we in general anesthesia straighten the rod without open surgery. The second was fracture on the rod because the fixation with the rod was not sufficient and the patient weight bearing immediately, so we make plating osteosynthesis. Here you can see the bending and then the straighten after the anesthesia. We developed with people from Czech factories, we developed nail for this locking nail lengthening, which we can lock from this side. We don't need X-ray to locking it distally, so it's quite simple. So the conclusion, Calotaxis is of course optimal choice for treatment of limb length discrepancy. Destruction to 4 centimeters, we used only external fixation. Destruction over 4 centimeters, we used combined method. In older patients, that means a patient over 25 years, we supposed it's useful also for lengthening of tibia. In some cases, we used intramedullary skeletal fixation. We have some special patients after trauma of the long bone when they have locking nail, a locked nail, and they are healed with shortening. We treated, we have 4 patients in this treatment, which I think is quite nice. We unlock the nail, put the external fixation, make osteotomy, and distract it to desired lens, and then again locked. So patients are satisfied that they don't need any other surgery. It's necessary for good result, good choice, and very cooperative patient. Thank you very much for your kind attention.